Today, I'd like to talk about stem cell therapy for the ischemic stroke from bench to from bayside, bench to the bayside. So, mainly done in my lab. It's 95% work is done in my lab in a couple years. So why I'm started stroke? Because the stroke still is the leading cause of the disability and the fifth leading cause of death in the United States. So generally speaking, ischemic stroke is caused by the clot, blood clot, So we call it ischemic stroke. Currently, there are a couple devices, couple in the treatment strategy. One is called the Mercy device. So they are putting the blood vessel to remove the clot. So this is this is only, for the large vessel, only large hospital can use that. So that's not, only few people can apply called Mercy device. And not only approved, FDA approved the drug is called the TPA. So this is, the TPA can dissolve the blood clot. This is the blood clot here. So, blood vessel before TPA treatment, after TPA treatment. However, the limitation of the TPA treatment is only occur in the 3 or 4.5 hours after onset of ischemic stroke. If beyond 4.5 hours stroke, then we administer the TPA, they cause a lot of side effects. For example, hemorrhage. So another reason is because the time it costs, only 2% of the ischemic stroke patient can be treatment with the TPA. So generally speaking, is don't have enough effective treatment available for the ischemic stroke so far. So in general speaking, after stroke, neuronal cell are going to die. There are two strategies. One strategy is prevent cell dies. Another strategy is replace the cell death. There are a lot of the neuroprotection drug, have been tried. It's work on the animal model, but in the clinical trial, none of them working, right? Why? Because the cell deaths occur really quickly. Maybe in a couple of minutes or 10 minutes or 20 minutes, But in the animal study, people in the injection cell protection, immediately after the ischemic stroke, of course, the cell going to die, the cell death is going to protect. However, in the clinical setting, the people in the patient found an onset of stroke, the family, found that, ambulance sent it to hospital, MRI, CT scan, make a diagnosis, because they are distinguishing. There's hemorrhage or ischemia. The treatment totally different. After that is a couple hours beyond, that. So the cell death already passed, occurring, was gone. So we cannot use neuroprotection drug protect cell death of the ischemia. So another strategy we work on. I'm working on since the 2001. Work on like neurogenesis and the stem cell. The stem cell, there are two characters. One is cell renewal. One is cell differentiation. So one cell, if a neural stem cell can differentiate the neuron, H cell or oligodendrocyte, these are called neural stem cell. In the old fashion, in the medical school, I was taught no dividing neuron in the brain. Since in 1999, so the people found that there's maybe some cell dividing cell in the brain. Eventually, I think that after 2001, the people found like a BRDO and the new antibody confirmed that the two regions in the brain have some stem cell existing. One is called in the supragranular zone of the hippocampus. There's the hippocampus in the dendrites. There's the supragranular zone. The stem cell existing here, they proliferate and migration into the granular layer. There's the evidence. This is called the BRDO injection. BRDO is substrate of the DNA synthesize. So a lot of BRDO pulse cell in the supragranular zone. This is the double coating, stem cell marker. See a lot of stem cell markers possibly here. Another region we call the supragranular zone of the lateral ventricle. So there's the lateral ventricle. There's the subventricle zone here. A lot of the BRDO pulse cell here. So generally speaking, cell in the subventricle zone migration to the olfactory bulb every day through called the rooster migratory stream. People, we don't know why. Why so many cell migration of olfactory bulb is still a mystery. We don't know yet. So as mentioned earlier, the stem cell ischemia can be like the hemorrhage because blood vessel broken, and one we call the ischemia and the hemorrhage. We start in ischemia because 85% stroke is ischemia stroke. So ischemia stroke is the most important the area. This is how we do the ischemia model. That's just showing that we use rats. We cut skin, open skull. This is the middle cerebral artery. We open the artery. We occlude. So we first found that after the ischemia stroke, neural cell is increased in the subventricular zone, because there's a focal ischemia. In the global ischemia, there are two types of ischemia. One called global ischemia, one called focal ischemia. In the global ischemia, they are mainly affecting the subgranular zone. In the focal ischemia, because they are mainly damaged the striatum, and the cortex is very adjacent to the subventricular zone. So in the focal ischemia, after the ischemia stroke, the neuronal stem cells still proliferate. Very interesting that after in the Asian rats, because stroke may occur in the Asian population, so we study in the aging and in the stroke. So in the Asian rats, the stem cells still responsibility after ischemia stroke, indicating that. So Asian rats retain the capacity for the repair. So as mentioned earlier, after ischemia in the subventricular stem cell in the subventricular zone, mainly migration to the olfactory bulb. This is called the rooster migrating stream. So, however, after ischemia stroke, we found that. See, this damaged region, this subventricular zone, in 0 hour, 8 hour, 16, 24, and 72 hour, stem cell proliferate. The number is significantly increase and migrate into the damaged region. See, this is the damaged region. So a lot of this kind of double coating and nesting is a stem cell marker. So the first couple slides we talk about the stem cells perforated in response to ischemia stroke. These slides we show that this is increase of perforated stem cell migration to the damaged region. This is the low power view showing that this is the striatum, this is the lateral ventricle, there's the subventricle zone, this is the stem cell area, this is damaged region. So many stem cells is green, the red is perforated, is BRDL pulse cell. So some is so many stem cells try to migration into the damaged region for repair. The issue that the stem cells repair the damaged region, so that's why some patient is recovered after ischemia stroke, some not, because if cell death number is too many, maybe not enough. The stem cell don't have enough capacity for the repair. I will talk about that later. So now we will try to verify, those stem cell migration to damaged region, those stem cells have functional or not, right? They're truly differentiation function neuron or not. So we use we generate GFP rich virus injection to the subventricular zone area. Because rich virus only infect dividing cell, not like lentivirus. So 24 hours later, we did a double immunostation, the GFP pulse cell also expression the double coating. This is stem cell marker, so indicating that the GFP pulse cell is a stem cell. So 1 month later, we use whole cell punch lab because it's green. So we can punch the cell, those kind of endogenous stem cell in the striatum, in the damaged region, because this whole cell is migration from to the subventricular zone to the damaged region. So we use this papaya, we use whole cell punch lab, indicating those green cell is functional neuron or no. So that's the we see that those cells have some potential activity. So those kind of potential activity can be blocked by the sodium activity can be blocked by TTX. So this indicating this cell is mature neuron because it has some action potential. Also, we found that those kind of cells have some EPSC and iPSC, right? So indicating that those stem cells of the ischemic stroke proliferate, migration, and differentiation to the mature neuron. Those kind of mature neurons also integrate local network. So next question, okay, those stem cell is truly functional contribution of recovery of the ischemic stroke or not? So we developed one of the transgenic mouse model. One is per model is double coding, use the HSV-TK. So this is how if we inject gancycline, so this will be in depletion of the neuronal stem cell. This is the model we developed. So this is the after injection GCV 14 days. This is normal vehicle. This is transgenic mouse model. So is this got a double coding? So majority of the cell is gone after injection. So this is BRDO. This is indicating proliferation cell in the subventricle zone. This is lateral ventricle. This is subventricle zone. So no BRDO, only few. Why only few? This cell is very, very slowly dividing cell. Majority is rapidly dividing cell. So it's very slowly. So a lot of the cell is depleted after the injection in the GCD in the double coding transgenic mouse model. So it's also showing in the hippocampus. As I mentioned earlier, there's dendrigars, there's supracranial. After injection, the GCD 14 days, the double coding pulse cell or neuronal stem cell almost gone. So we did a double immunostain, triple immunostain, double coding, BRDO, GFAP. GFP is HSL marker. So not affect HSL, but the BRDO and double coding is almost gone. The GFP cell is still there after injection. So this is the normal migration pattern in the wild type. So after injection, the JCV, transgenic mouse model, is migration almost gone. So then we did that. We did use this model. We did ischemia stroke. Treatment in the vehicle and treatment in the JCV, right? So the infarction volume is significantly increased, right? So if the depletion of the neural stem cell, the infarction volume is increased. And we also use another model, the function, test to see the motor function has been effect or not. So injecting, the vehicle and the JCV, see the neurological score deficiency increase. And also lean place test is another motor function showing that also getting worse. So that's in the human section. This is called ischemia in the human brain. This is called hemorrhage in the human brain. So in the last couple years, we mainly focus on the chronic stroke because in the acute stroke, if we injection the stem cell, I think a lot of couple lab like Gary Steinberg lab in the Stanford and other like a lab uses stem cell treatment for the acute ischemia stroke. They said recover not. It's difficult to say that because some stroke patient, even without any treatment, they will be recovered, partially recovered. So it's difficult to say that the patient recovered because your injection of the stem cell or because it's a cell. Because they don't have any control. The control is self-control. So it's very difficult assessment. But we know that, as I mentioned earlier, that the stroke is the leading cause of disability in whole world. Why? Because after ischemia stroke or after hemorrhage stroke, the brain will be gone. They form the cavity because all cells dead. The dead will be absorbed by like a macrophage. There's the MR scan showing the cavity. So can we inject stem cell in the cavity? You can, but you don't have the matches. Look like a wall of the concrete. You don't have concrete, only brick. You cannot, form the wall. So we have to use the tissue engineering approach, right? So this is why I need a tissue engineer, because we need, first of all, don't have enough, the stem cell, endogenous stem cell. Second of all, there's some glial skull wall surrounding the cavity. So even stem cell migration to the damaged region, because of the glial skull, there will be restriction cell migration into the cavity. So it's impossible. So we need a stem cell, need a mechanical support, right? So yeah. So first of all, we use the human embryonic stem cell, injection in the brain. Okay, so we look at it's very popular. I think that's the first a couple years ago. So we injection like a human embryonic stem cell in the rat brain. It's caused tumor, right? But we have to. The human embryonic stem cell differentiation to neural stem cell injected brain is not a formed cavity. So we use, this is the cell line, is NIH approved the cell line called the VG01. So the differentiation to the mature neuron, into the neural stem cell. The in vitro first. So we did like a SOX2, nesting, showing that the mature marker is not gone. Oligodendrocyte and the astrocyte is not positive. So we indicating that those auto cell is neural stem cell. It's not astrocyte, not oligodendrocyte. So this we did MCO. MCO is a stroke. So transplantation 2 months, 3 weeks later, then couple months later we killed it. So this is the vehicle. This we use the matrix gel only. This is the stem cell only. This is the strategy we put on the cell and the gel together, mix together in the in vitro, then put in the cavity again. This is the mix called this is the gel is at 4 degree is gel, right? Or is liquid. When you put in turn the 37 degree, it becomes the gel. So we use the cell gel mixed the meshes together before the injection. So that's the cavity. So that's the cavity. So after use the tissue engineer approach, the cavity almost gone, right? So that's the large view of we see a lot of stem cell still in the cavity, right? This is the called anti-human nuclear antibody, because this is the stem cell, human embryonic stem cell. We inject in the rats, so we use the anti-human nuclear antibody. See a lot of the stem cell still there after a couple months later. So this the silent test is for the motor function, and Y-maze is a cognition test. See there's a significantly different. So and again, the people also ask us, does transplantation cell or implant cell is functional or not? So because we injection cell contains GFP positive, is positive cell. So we can able to use a whole cell punch clap to detect the implant cell. Again, we can see the action potential and the action potential and the EPSC. So the next we try to use a clinical setting, right? We want to eventually use a clinical setting. Human embryonic stem cell. We cannot use human embryonic stem cell for the clinical trial because the human embryonic stem cell still have some risk. So first of all, we try to develop like the scaffold, right? The scaffold. The previous couple slides I show you that scaffold is called the matrix gel. The matrix gel is from the tumor. So now we cannot use the matrix gel from tumor injection in the human patient. So we developed another strategy called the plasma or serum. We can add the thrombin, so we can control the intensity of the gel. of the plasma. That's we did that. Different concentration. If the cat in the thrombin, calcium only. So the fact that calcium, and if we add the calcium, we want to see the calcium is toxicity or not. So we did that. It's not. There are different concentrations. So the also different concentration of the plasma also affect the cell or not. So we did that. So only like a cell culture, like a 10%, 20%, 30% is okay. It's not affect the cell surviving, but the high concentration, like 50%, 60% of serum, kill the cell. So we did that. Use the scaffold is from the plasma, and the MPC is neuroprogenesis, and scaffold only. See the HF volume, because we not called the infarction volume. Infarction volume is after a couple months later the breeze trough, so it's not called infarct. It's the trough. The trough volume is significantly different. Also the behavior, also is significant difference as well. This is the strategy how we inject in the stem cell. So that's the infarct. We try to understand why the use tissue engineer approach reduce the infarction volume or atrophy volume and improve the motor function. So this is the chronic stroke. There's penumbra we call the pre-infarct region. This is the cavity. So that's the after ischemia stroke. So we use the tissue scaffold. This vehicle only scaffold and plus neural stem cell. With this thing we call the lectin. You see a lot of the blood vessel angiogenesis in the existence. Think about that. If a cell in the cavity without the oxygen supply, the cell going to die, right? So we injected that. We found a lot of we just injection stem cell in the scaffold, a lot of blood vessel. That's very surprising. We didn't expect that. So we measured the oxygen. We measure the number of the blood vessel. So it's significant increase, right, after injection, the stem cell and scaffold, and also the length of the blood vessel and the area of the blood vessel. So to couple, the toll to determine angiogenesis is real or not. And also, as mentioned earlier, there are some glial scar surrounding the cavity. There's a glial scar. The glial scar is mainly consistent of the GFP, positive cell, the H cell, and the matches. So after the injection, NEPC, tissue engineer approach, the glial scar almost gone. So we remove, there's some of the mechanism remove the glial scar. So not just only increase the angiogenesis, also remove the glial scar. This makes sense because then the stem cell in the cavity can migration into the pre-infarct area. So cross-talking to hosting cell. This is the scar thickness, how thick of the scaffold, the scaffold. This is how see because the fibrogen, so the plasma or serum will be degradation in the future because the plasma is not exist in the cavity forever. Sooner or later, the plasma will be degraded and the stem cell will be released, so the matches replace the plasma or serum. So we did we did one of the case study. So this one 50 years old stroke patient with left side paralyzed for 6 months. So it's called conservative chronic stroke. In the clinical setting, if generally speaking, in the first 3 months, the stroke can be recovered. After 3 months, still not recovering, conservative is difficult. So after 6 months, so this patient this patient cannot stand up, cannot take a shower. His wife is a nurse, in the hospital, one of the medical hospital. So it's not happy, right? Because cannot take a shower, eating whatever, so go to bathroom, you have someone take care of the patient, right? So, so we use because we use cell from bone marrow stem cell from own patient. As mentioned, we cannot use the neural stem cell from human embryonic stem cell injection on patient. It's not an issue. We use the own patient stem cell, own blood plasma generated scaffold, right? So everything from patient own. So we did surgery. So because they have some cavity, right? So the cavity we have MRI, we can use the needle, we can see here where we go. We can exactly injection the cavity of the stem cell. So this is this patient cavity, right? So after the injection, MRI, cavity almost gone. It's bigger, smaller. Particularly the neurites, right? Because this patient has a cavity. The neurites is gone, almost gone. This cavity almost gone here. Everything gone. So before treatment, after treatment, see that? There's a lot of neurites comes through the cavity. There's strong evidence, right? That's the I have some video. It's moving, stand up, can walking. 6 months later after the implantation. See? Was on the wheelchair. Actually, this is the first case in the world. Now one work on the chronic stroke, particularly use the tissue engineering approach. Right? So we also did a neurologic score. So that's the we have the best index MMSC, so indicating that see that different days after treatment. There's a cognition test. See, they are gradually improve every week, not every day, every week. 1 year later, see, that's the evidence. So I have did another case, This is the woman, had a trauma. 16 years ago. 16 years ago, had a car trauma, car accident. The half brain will be gone. After the trauma, went to the hospital, they lost conscience. Don't have anything. There are people say that we call the brain die, right? They're hopeless. Surprised that 6 months later, the patient wake up, for some reason. I think it's because very young at their time. So the patient is paralyzed, cannot speak, only can speak one word, called mom, like a mom, in China. No other words. How can go to bathroom because paralyzed? There's like this, go bathroom, pee, like this, this kind of stuff. So it's difficult. I just did the 1.5 years ago. We did that. So this we see that one side is okay, before body movement, right side before the movement. So this is because half brain is gone, so many cavity, because trauma, not ischemic stroke. So before surgery. So this half brain, because the side, if it's go to side, is half brain gone. This is half, we try to open the skull here. See, that's the, is almost no brain. It's also the scar and so many cavity inside here. That's the, this is the cavity. Inside all cavity, all brain cavity. So we did that. But this is difficult because 16 years ago, you know, half of brain is gone. So we want to see. Yeah. Yeah, almost gone. Yeah. I have 2 more slides. This is the last slide. They can speak. I don't have the video. Because anyway, was cannot speaker, that they can speak, right? Can add the speaker 3 words, no more. 3 words. I want, you know, how are you? Something like that. But at least making progress. And also the patient has some epilepsy, it's gone. All right, I'm stopping here. Okay, the question is that can we take the stem cell from the nose for treatment of ischemic stroke? In theory, it's okay because but we didn't do any culture because the stem cell from the nose, the number is too small. We cannot direct the injection. If the in vitro culture again, it's caused a lot of issue. Growth factor, serum is have been proved. If we inject in the patient, will be cause the allergy or the GVHD, you know, there's a lot of issue. So we do that because of the cavity, we need a lot of cell, right? But the sperm count injury maybe is okay, you know, the sperm.
These are autologous cells that are essentially multiple stem cells. These are not reprogrammed stem cells, correct?
No, yeah, no. The question is reprogrammed cell or not? It's not reprogrammed cell.